Transcanal facial nerve decompression, transcanal, within the canal facial nerve decompression from meatal foramen to stylomastoid foramen, meatal foramen to stylomastoid foramen, meatal foramen to stylomastoid foramen. Indications, meatal foramen to stylomastoid foramen. The indications are longitudinal temporal bone fractures causing facial nerve palsy and unresolved cases of Bell's palsy. Longitudinal temporal bone fractures causing facial palsy, longitudinal temporal bone fractures causing facial palsy, and unresolved cases of Bell's palsy. It's performed in 3 steps. Now, tracing the nerve. The performance in 3 steps, tracing the nerve from second geno to geniculate ganglion. From second geno to geniculate ganglion. From second geno to geniculate ganglion. From geniculate ganglion to mental foramen, meatal foramen. From geniculate ganglion to meatal foramen. From geniculate ganglion to meatal foramen. And third one is second geno to stylomastoid foramen. Second geno to stylomastoid foramen. Second geno to geniculate ganglion to meatal foramen. Second geno to stylomastoid foramen. Procedure: tympanotomy. Number 1, tympanotomy. Next, number 2, canaloplasty is done during conical burr for good exposure. Canaloplasty, tympanotomy, canaloplasty. Removal of the scutum to expose the IS joint. Removal of the scutum to expose the IS joint. Disarticulation of the IS joint. Disarticulation of the IS joint. Remove the incus by rotating long incudal process. Remove the incus by rotating the lip upward using smooth curved pick or ball probe. Smooth curved pick or ball probe, both can be done. Rotate the lip up, lip to lift up. Remove the head of the malleus, HOM, using malleus nipper for good exposure of anteradic space. HOM is removed means you will expose the arse. HOM, you remove the arse. HOM is removed, you expose the arse. HOM is removed, you expose the arse. Using 2-0 diamond burr, perform atticotomy to get good exposure of horizontal segment of facial canal. Perform atticotomy with 2-0 diamond burr. Atticotomy. Get exposure of horizontal segment of facial canal. Horizontal segment of facial canal. Horizontal segment of facial canal. Geniculate ganglion and supralabyrinthine area. 2-0 diamond burr, atticotomy for exposing horizontal segment of facial canal, geniculate ganglion, supralabyrinthine area. Supralabyrinthine area. Horizontal segment of facial canal, geniculate ganglion, supralabyrinthine area. First one, tracing the nerve from second geno to geniculate ganglion. Second geno to geniculate ganglion. The horizontal segment of facial nerve identified from second geno to geniculate ganglion. Second geno to geniculate ganglion. Second geno landmark is 1 millimeter medial and inferior to lateral semicircular canal. 1 millimeter medial and inferior to lateral semicircular canal. And it is posterior and lateral to pyramidal process. Posterior and lateral to pyramidal process covered by facial recess cells. Posterior and lateral to pyramidal process covered by facial recess cells. Posterior and lateral to pyramidal process covered by facial recess cells. The bony canal over second geno is eggshelled using diamond burr. Bony canal is eggshelled during diamond burr. Horizontal segment of facial canal courses superiorly medial to SIP. Horizontal segment of facial canal is superior just medial to SIP, short incudal process. SIP. Horizontal segment of facial canal superiorly just medial to SIP, short incudal process at fossa incudis. And runs superior to the oval window and posterior to CP, cochleariform process. And superior to the cochleariform process. Superior to the oval window and posterior superior to the cochleariform process. It's an important landmark. Cochleariform process is an important landmark for facial nerve in the middle ear. Horizontal segment of the facial canal courses superiorly medial to SIP at fossa incudis and superior to the oval window and posterior superior to the CP, which is an important landmark for facial nerve in the middle ear. Horizontal segment of the facial canal courses superiorly just medial to SIP at fossa incudis, superior to oval window and posterior superior to cochleariform process. It is an important landmark for facial nerve in the middle ear. Beginning of the horizontal segment is marked by cog and cochleariform process. Horizontal segment beginning is marked by cog and cochleariform process. Cog and cochleariform process mark the beginning of horizontal segment. Bony canal over horizontal segment is comparatively thinner than vertical segment. Thinner than vertical segment. In 50% of the cases, bony canal is dehiscent over the horizontal segment. In half of the cases, bony canal is dehiscent over the horizontal segment, which is thinner, 50%. Using 20 or 30 diamond burr, gently bony facial canal, burr the bony facial canal over the horizontal segment, which is eggshelled with profuse irrigation. So horizontal segment is eggshelled with profuse irrigation. Eggshelling of horizontal segment of facial canal. Eggshelling of horizontal segment of facial canal. So tracing of the nerve from second genu to geniculate ganglion. Horizontal segment is identified from second genu to geniculate ganglion. The landmark for second genu is 1 mm medial and inferior to lateral semicircular canal. Medial and inferior to lateral semicircular canal lies lateral and posterior to pyramidal process. Lateral and posterior to pyramidal process, which is covered by facial recess cells. Bony canal over second genu is eggshelled using diamond burr. The horizontal segment of the facial canal is superior in course, medial to the sip at the fossa incudis, and superior to the oval window and posterior superior to the cochleariform process. And beginning of the horizontal segment is marked by cog and cochleariform process. Bony canal over the horizontal segment is comparatively thinner than vertical segment. Second step is tracing the nerve from geniculate ganglion to meatal foramen. Geniculate ganglion, GG to MF. GG to MF. Geniculate ganglion to meatal foramen. Geniculate ganglion is 3 to 4 millimeters anterior and superior to cochleariform process. GG is 3 to 4 millimeters antero-superior to CP. GG is 3 to 4 millimeters antero-superior to CP. Bone over the geniculate ganglion, GG, is more cellular, drilled by diamond burr, leaving an eggshell bony covering. GG bone over it is cellular, so eggshell. GG is dehiscent in 15% of the cases, 10 to 15% of the cases, at risk during middle cranial fossa procedure. GG is dehiscent in 10 to 15% of the cases and is at risk during middle cranial fossa procedure. Bone of TT is very thin in this region. Bone of tegment tympani is very thin in this region. Cochleariform process and geniculate ganglion. Cochleariform process and geniculate ganglion. Next is decompression of greater superficial petrosal nerve. Greater superficial petrosal nerve is a branch of geniculate ganglion. GSPN is a branch of GG. GSPN is decompressed by curating the peritubal and supratubal air cells. Peritubal and supratubal air cells using zero size curate. Curate the peritubal and supratubal air cells with zero curate. Nerve is traced up to facial hiatus. Nerve is greater superficial petrosal nerve is traced up to facial hiatus where it exits. Facial hiatus, exit of GSPN. Facial hiatus is exit of GSPN. It is important to decompress GSPN in a cadaver temporal bone. GSPN is decompressed in cases of longitudinal fractures and in cases of unresolved Bell's palsy along with facial nerve. GSPN is a must to be decompressed in longitudinal fractures and unresolved Bell's palsy. Decompression of greater superficial petrosal nerve by removing the peritubal air cells. Peritubal air cells. Next is decompression of labyrinthine segment. Labyrinthine segment. Labyrinthine segment is a delicate part of dissection. Requires a lot of patience and time consuming. Labyrinthine segment is time consuming. Labyrinthine segment is time consuming. Labyrinthine segment is medial to lateral for about 6 millimeters long from fundus to GG. From fundus to GG. Labyrinthine segment runs medial to lateral, from medial to lateral, 6 millimeters long, fundus to GG. The narrowest and shortest segment of facial nerve, which includes the GG. Lab includes the GG. Lab includes the GG, narrowest and shortest segment of facial nerve, from medial to lateral, from fundus to GG. Fundus to GG. Term labyrinthine segment is suitable because labyrinthine segment is bounded anteriorly by cochlea. Lab is bounded anteriorly by cochlea and posteriorly by the ampullary end of the lateral and superior semicircular canal. Posteriorly bounded by ampullary end of L and S. Posteriorly bounded by ampullary end of lateral and superior semicircular canal. This segment lies between tegmen plate superiorly and vestibule inferiorly. Labyrinthine segment lies between tegmen plate superiorly and vestibule inferiorly. Tegmen plate superiorly and vestibule inferiorly. Tegmen plate superiorly and vestibule inferiorly. Labyrinthine segment is suitable because labyrinthine segment is bounded anteriorly by cochlea, posteriorly by the ampullary end of lateral and superior semicircular canal, lies between tegmen plate superiorly and vestibule inferiorly. Anteriorly cochlea, posteriorly is the ampullary end of lateral and superior semicircular canal, tegmen plate superiorly and vestibule inferiorly. To expose the labyrinthine segment of the nerve, supralabyrinthine cells are removed. Supralabyrinthine cells are removed with 0.6 mm diamond burr and profuse irrigation. Supralabyrinthine cells are removed 0.6 mm diamond burr. Using 0 or 1 size curette, rest of the supralabyrinthine cells are removed gently. This step is difficult in case of sclerotic mastoid and low-lying dura. Most of the supralabyrinthine hair cells are removed using a curette. While curetting, sharp edge of the curette is directed away from the nerve. And smooth surface of the curette touches the nerve, causing no pressure. Sharp edge away from the nerve. So decompression of GSPN by removing the peritubular hair cells and decompression of GSPN by removing the supratubular hair cells. Greater superficial petrosal nerve, geniculate ganglion, cochlear form process, and facial hiatus. Removal of supralabyrinthine cells using 0.6 mm diamond burr. Supralabyrinthine hair cells using 0.6 mm diamond burr. Next, geniculate crust. Geniculate crust is a sharp bony ridge between labyrinthine segment and tympanic segment. Curated with sharp and stout zero size curette. Geniculate crust, a ridge between labyrinthine segment and tympanic segment. Between L and T is a geniculate crust. Removal of geniculate crust gives good exposure of labyrinthine segment of more than 180 degrees of the nerve. Removal of geniculate crust gives good exposure of the labyrinthine segment of more than 180 degrees between L and T parts, that is labyrinthine and tympanic segment. Avoid removing excess of labyrinthine bone beneath the labyrinthine segment and GG. Avoid removing excess of labyrinthine bone beneath the labyrinthine segment and GG. Since cochlea lies anterior to labyrinthine segment, you have to avoid. Avoid removing excess of labyrinthine bone beneath the labyrinthine segment and geniculate ganglion. Using a curette is safer than rotating burr in decompressing the labyrinthine segment. Using a curette is safer than rotating burr. In decompressing the labyrinthine segment. Because ampullary end of lateral and superior semicircular canal, and superior semicircular canal, L and S, are unlikely to get damaged with a curette, which lies posterior to the labyrinthine segment of the facial nerve and is the hardest bone. It lies posterior to the labyrinthine segment of the facial nerve and is the hardest bone. So removal of the supralabyrinthine hair cells using 0.6 mm diamond burr and decompressed labyrinthine segment. Decompressed labyrinthine segment. Next, removal of supralabyrinthine hair cells using a curette. Next, supralabyrinthine hair cells are curated until the meatal foramen is exposed. Supralabyrinthine hair cells is curated until the meatal foramen is exposed. Labyrinthine segment is identified by change in the color of the nerve. Labyrinthine segment is identified by change in the color of the nerve. Fibers are loosely arranged without any epineural covering. Fibers are loosely arranged without any epineural covering. Without any epineural covering, occupying about 83% of available space in the fallopian canal. Occupying about 83% of the space in the fallopian canal in this segment compared to 73% in tympanic segment and 64% in vertical segment. 73% in tympanic segment and 64% in vertical segment. 73% in tympanic segment and 64% in vertical segment. So 83% occupation in the case of without any epineurium in the case of labyrinthine segment, that is in the fallopian canal, compared to 73% in the tympanic segment and 64% in the vertical segment. That is decreasing. Bottleneck constriction at the entrance of the fallopian canal is described as meatal foramen. Bottleneck constriction at the entrance of fallopian canal is described as meatal foramen. A special name for its anatomical structure is justified because it is the narrowest part of the canal, measuring about 0.7 millimeters in diameter. Narrowest part of the canal measuring about 0.7 millimeters in diameter. Thus the labyrinthine segment is traced up to the meatal foramen. Bottleneck constriction at the entrance of the fallopian canal is described as meatal foramen. A special name is justified because it is narrowest part, 0.7 millimeters in diameter. Thus labyrinthine segment is traced up to meatal foramen. Next, tracing the nerve from second genu to styloid foramen. Second genu to styloid foramen. From second genu, trace the nerve to vertical segment by further widening the canal. Using 3-0 diamond burr until the chorda tympani nerve is identified. Trace the nerve to vertical segment. By further widening the canal using 2-0 or 3-0 diamond burr until the chorda tympani is identified. Using 3-0 diamond burr, keep widening the bony annulus till the shadow of vertical segment of facial nerve. Keep widening the annulus till the shadow of vertical segment of facial nerve is seen up to stylomastoid foramen. With a diamond burr, widen the bony annulus till the shadow of vertical segment of facial nerve is seen up to stylomastoid foramen. The relationship of vertical segment of facial nerve to tympanic annulus is very important. Vertical segment of facial nerve to tympanic annulus relationship, especially in the posterior inferior quadrant of the annulus. The nerve may cross lateral to the annulus in this quadrant, making susceptible for injury. The nerve may cross lateral, making susceptible for injury. Keep watching for the color change. The nerve is pinkish in color and perifacial blood vessels are seen running along the nerve in living body. Nerve is pinkish in color and perifacial blood vessels are seen running along the nerve in the living body. And white color is seen in the cadaver bone. Facial nerve from stylomastoid foramen to second genu is exposed. From stylomastoid foramen to second genu is exposed. Bone covering is thin to eggshell consistency. Bone is eggshelled out. Always keep an eggshell bony covering over the facial nerve.
over the facial nerve. Over the facial nerve. Always keep an eggshell bony covering over the facial nerve. Care is taken not to injure the epineural sheath of the facial nerve. Epineural sheath of the facial nerve. Using Plaster's knife, eggshell bony covering of the facial nerve is removed. Eggshell bony covering of the facial nerve is removed. Utmost care is taken not to damage the stapes while removing the eggshell bone. Over the horizontal segment. Care is taken not to damage the stapes while removing the eggshell bone. Remove the bony covering for 180 degrees. Thus the nerve is unroofed from meatal foramen to stylomastoid foramen. Decompression of the facial nerve. Decompression is complete after incising the sheath of facial nerve. A sharp tenatome and micro scissors, the sheath is incised. Start incising the sheath retrogradely from stylomastoid foramen to geniculate ganglion. Sheath of the vertical segment is thicker. Vertical is thicker. Horizontal is thinner. And geniculate ganglion also thinner. Vertical is thicker. Sheath over GSPN is also incised. Labyrinthine segment does not require any decompression as it is devoid of epineurium. Labyrinthine segment is devoid of epineurium. No decompression is required. Thus the nerve is decompression from the meatal foramen to stylomastoid foramen. So greater superficial petrosal nerve, geniculate ganglion, labyrinthine segment, meatal foramen, horizontal segment. Next, eggshelling of the vertical segment of the facial canal. Removing of the eggshell bone. Next, cochleariform process, horizontal segment, vertical segment. Unroofed facial nerve, incising the facial nerve sheath from below to upwards. Incising the sheath of vertical segment. Incising the sheath of horizontal segment. First is vertical segment, then horizontal segment. Next, incising the sheath of geniculate ganglion. Incising the sheath of GSPN. Decompressed labyrinthine segment. Epineurium is absent, therefore decompression is not that much required. Labyrinthine segment, meatal foramen. Decompressed horizontal segment and geniculate ganglion. Decompressed horizontal segment and vertical segment. Pitfalls. Further damaging the facial nerve. Then damage to chorda tympani nerve. Subluxation of the stapes. Injuring the lateral and superior semicircular canals. Injuring the superior wall of internal auditory meatus. IAM. Decompression of labyrinthine segment of the facial nerve is difficult in a sclerotic mastoid. One has to master the decompression of labyrinthine segment of the facial nerve through transcanal approach. Transcanal approach to decompression of the facial nerve is safe, easy, cost-effective, and less morbid in compared to middle cranial fossa approach, which is difficult due to narrow operative field, inverted surgical position, obscured landmass in the floor of the middle cranial fossa, and postoperative morbidity due to retraction of the temporal lobe of the brain. So middle cranial fossa is bad. Transcanal approach is good for facial nerve, easy, safe, cost-effective, less morbid. Middle cranial fossa is difficult, narrow operative field, inverted surgical position, obscured landmarks on the floor of the middle cranial fossa, and postoperative morbidity is due to retraction of the temporal lobe of the brain.